The final chapter of this tutorial covers pacing, electrolyte abnormalities, and a few other issues which do not fit cleanly into the other chapters. Pacemakers and other pacing devices will always have either 1, 2, or 3 wires depending on their function. A single lead pacemaker can be placed either in the atrium or the ventricles. In either situation, it can only pace or sense in the chamber in which it is present. Almost all single lead pacemakers are placed in the ventricle alone. Dual chamber pacemakers have a lead in the right atrium and in the right ventricle. And finally, cardiac resynchronization therapy devices, which are abbreviated CRT, have a lead in the right atrium, the right ventricle, and the lateral wall of the left ventricle. On the 12-lead ECG in front of you, you can see that the QRS is wide and that a pacing spike is present in front of each QRS. Clearly, ventricular pacing is occurring on each and every beat on the 12-lead ECG. In addition, there is a pacing spike visible approximately 160 milliseconds in front of the ventricular pacing spike. This is most easily seen in leads 2, 3, and AVF, as well as leads V3 through V6. This is typical and classic dual-chamber pacing. The atrial pacing spike is followed by a reproducible and organized P wave. This is best seen in leads 2 and 3. In some of the other leads, the actual P wave is not cleanly visible. Remember, the P wave will not have the expected normal sinus rhythm appearance. The appearance of the P wave in atrial pacing depends entirely on the location of the atrial pacing lead. The paced ventricular complex is typically wide, just like the one on this 12 lead, and of course repolarization abnormalities are present. Whenever depolarization is abnormal, then repolarization will be abnormal as well. Pacing is a typical example of both depolarization and repolarization abnormalities. In this recording, you should be able to see that the QRS is completely normal, both in duration and morphology. The P waves, on first glance, may look quite normal. The P wave in lead 2 is clearly upright, it is upright in lead AVF, and it is inverted in AVR, and one might think this was a sinus P wave. However, there is clearly an atrial pacing spike present. This is most easily seen in lead 2. This particular 12-lead ECG illustrates the importance of looking at every lead every time. ECG interpretation requires a systematic and organized approach to the review of the tracing in question. If you looked at every lead here, leads V1 and lead 2 both clearly have atrial pacing spikes which precede the P wave. The correct interpretation for this 12-lead ECG would be atrial pacing. It is important to note that we do not know whether or not this is a dual-chamber pacemaker. We only know that only atrial pacing is occurring at this moment in time. Because conduction is present between the atria and the ventricles during the time of this recorded 12-lead, it may well be that this patient has a dual-chamber pacemaker, but the ventricular lead is quiet at the present time because native conduction is occurring. In this recording, I hope it is obvious at first glance that there are more P waves than there are QRSs, and that there is no association between the Ps and the QRSs. The atrial rate is running at one rate, which is approximately 130 beats per minute, and the ventricular rate is running considerably more slowly, at approximately 40 beats per minute. Therefore, third-degree heart block is clearly present on this 12-lead ECG. In addition, you should be able to see that every QRS on this 12-lead ECG, with the exception of the third beat, is being driven by a ventricular pacemaker. Again, the ventricular pacing spikes are not overtly obvious on every lead of the ECG in front of us. However, lead V5, which is seen in its normal location in the precordial leads, but also across the bottom in the rhythm strip, clearly has a ventricular pacing spike in front of each and every QRS, with the exception of the one early beat, which is in the third position. The correct interpretation for this 12-lead ECG would be sinus tachycardia with third-degree heart block and ventricular pacing. So far, we have seen examples of single-chamber atrial pacing, single-chamber ventricular pacing, and dual-chamber pacing. This final 12-lead ECG represents cardiac resynchronization therapy. In fact, 3 different chambers are being paced. The normal right atrial and right ventricular leads are clearly present and functioning. It is a little bit difficult to see the atrial pacing spike, but if you look in leads 2 and 3, there is a very small pacing spike in front of each of the P waves. Therefore, atrial pacing is occurring. In addition, ventricular pacing is occurring. We can easily see the large pacing spike which is present in front of each QRS. But what is unusual about this particular QRS is that it is relatively narrow. This QRS doesn't look anything like the complex present on ventricular pacing or dual chamber pacing. This QRS is relatively narrow. It has an unusual axis and an unusual morphology, but its very narrow nature is the clue that this is cardiac resynchronization therapy. By pacing both the right ventricle and the left ventricle concurrently or in sequence, we can narrow up the conduction through the chambers, resulting in a more narrow QRS. The clues to this are the fact that the QRS is relatively narrow and lead 1 is downgoing. Lead 1 being downgoing means that the vector of depolarization is moving away from the left arm and towards the right. This can only happen if the source of the signal is beginning in the left ventricle. Therefore, if pacing is occurring, and it is occurring in the left ventricle, and it is narrow, it is almost certainly cardiac resynchronization therapy. The following 12-lead ECG represents a very specific pattern that is important to recognize. If we look, the heart rate is quite normal and well within the normal values. The P waves are upright in leads 2, 3, and AVF. However, they're also upright in lead AVR. This is an unusual phenomenon and normally would make us think of an ectopic atrial rhythm. In other words, a rhythm not originating in the sinus node. The P wave is inverted in lead 1. When we then move to the axis, we can see that lead 1 is distinctly negative and AVF is upright. That makes the axis a marked right axis deviation. The rest of the ECG is completely normal. This is a very typical pattern for left arm, right arm lead reversal. When you accidentally switch the left arm and the right arm leads, lead 1 flips upside down, which is exactly what's occurring here. Lead 2 and 3 reversed from each other. The lead labeled lead 2 is really lead 3, and the one labeled 3 is 2. AVR and AVL are also reversed. AVF is normal, and leads V1 through V6 are normal. That's why we see this pattern. Whenever you see a P wave that is right side up in lead AVR, upside down in AVL, and lead 1 is flipped upside down, this is left arm, right arm lead reversal. This must be distinguished from dextrocardia. Dextrocardia is when the patient's heart was flipped backwards embryologically and is on the other side of the patient's chest. That will manifest with this exact same limb lead pattern. However, leads V1 through V6 will not be normal. There will be regression of the QRS voltage across the precordium because you are moving further and further away from the heart as you move from V1 to V6. Therefore, when we see this pattern, think either dextrocardia or limb lead reversal, and look at the precordial leads. If they are normal, then it is left arm, right arm reversal. This 12-lead ECG has been obtained from the very same patient as the one before, only the left arm, right arm reversal has been corrected. We can see that lead 1 has turned upright, leads 2 and 3 have reversed, leads AVR and AVL have reversed, AVF is the same, and leads V1 through V6 are the same. This is confirmation that the left arm, right arm reversal was the cause of the unusual findings on the first 12-lead. As we first look at this 12-lead ECG, the first thing that should appear is that mild bradycardia is present. The heart rate is just under 60 beats per minute. There is one P wave in front of each QRS, and that P wave is upright in leads 2, 3, and AVF. However, the P wave is not clearly inverted in AVR, but is inverted in AVL. Additionally, lead 1 has an inverted P and a downgoing QRS. This is very similar to the left arm, right arm reversal that we saw in the previous ECG. Whenever we see this pattern, the most common explanation is indeed that the left arm and right arm leads were reversed. We then look at the precordial leads, because the precordial leads would be unaffected by that error in hookup. As we look, there is regression of the R wave across the precordium. The QRS voltage gets smaller and smaller as we move basically from lead V2 through V6. By the time we get to lead V6, the QRS is quite small. This, unlike the previous example, is not left arm, right arm reversal. This is dextrocardia. This patient was born with the heart formed as a mirror image of the normal placement, so that the apex points not towards the left, but towards the right. The correct interpretation of this 12 lead would be normal sinus rhythm with dextrocardia. Examine the 12 lead ECG in front of you carefully. You should be able to see that there are abnormalities of the ST segments and T waves. These abnormalities are fairly diffuse in nature and have a very specific appearance. The ST segment has a gradual transition from the R wave to the ST segment. This is particularly seen in lead 1, 3, and V6. This swooped appearance to the ST segment, along with the flattening and inversion of the T waves, is called digitalis effect, or dig effect. It is most commonly seen with therapeutic doses of the medicine digoxin. This 12-lead ECG was chosen because of the presence of prominent U waves. U waves are abnormalities in repolarization which appear after the T wave. They can be quite similar in appearance to the T waves themselves, but are usually distinct from those waves. In this 12-lead, leads V1, V2, and V3 manifest very prominent and clear U waves. The presence of a U wave is not necessarily pathologic, and is generally only commented on in the interpretation of the 12-lead. The typical reading for a 12-lead such as this would be prominent U waves. Remember, however, that hypokalemia can cause the appearance of a U wave that was not previously present. In this 12-lead ECG, numerous abnormalities should be immediately apparent. First of all, the T waves are very peaked and prominent throughout the 12-lead recording, but particularly in leads 2, 3, V4, V5, and V6. These are called peaked T waves. If you recall, peaked T waves can be a manifestation of early myocardial damage. However, the QRS in this 12-lead has been widened slightly so that there is a non-specific intraventricular conduction delay. Additionally, the P waves are almost non-visible in this 12-lead, but if you look carefully, they are still present in front of each QRS. This is a typical 12-lead for marked hyperkalemia, or elevated potassium levels. The first thing that happens in hyperkalemia is peaking of the T waves. As the potassium level continues to rise, the QRS will widen such that you almost get a sinusoidal pattern between the QRS and the T wave. The P waves become less and less prominent as the potassium level rises. The correct interpretation for this 12-lead would be marked hyperkalemia. The final abnormality that I wanted to discuss in this chapter is seen in this 12-lead ECG. I hope you can see that there is marked sinus bradycardia. The heart rate is extremely slow, and there is first-degree AV block present. The PR interval has prolonged slightly. At the very end of the QRS is an upward rising to the J point that immediately plummets back to baseline. This abnormality is best seen in leads 1, 2, 3, AVF, V4, V5, and finally V6. This is called an Osborn wave. An Osborn wave is quite rare because of its cause, but is essentially diagnostic of the problem. This 12-lead ECG is typical for hypothermia. When the patient's core body temperature has plummeted, marked sinus bradycardia occurs, PR segments prolong, the QRS duration prolongs, the QT interval can prolong, and an Osborn wave appears at the very end of the QRS and the beginning of the ST segment. The correct interpretation for this 12 lead would be sinus bradycardia with mild first-degree AV block and Osborn waves consistent with hypothermia.